Today we're going to talk about the updated treatment algorithm for pulmonary hypertension that was discussed at the 6th World Symposium. We're going to concentrate specifically on the initial steps and what is the role for initial monotherapy. This is an overview of the treatment algorithm. The important points including that the diagnosis needs to be confirmed, ideally in an expert center. There are some general measures and supportive therapy, that it's important to do acute vasoreactivity testing to find those patients who may do well on calcium channel blockers. And then for those patients who are non-vasoreactive, we stratify them based on their risk and make treatment decisions of monotherapy, oral combination therapy, or even more aggressive therapy. Another important point is that we need to continuously reassess patients and try to get them into the low risk status. Let's talk about the first section of the algorithm and specifically highlight those patients who might be appropriate for calcium channel blocker therapy. At the time of the initial right heart catheterization, it is important to do an acute vasoreactivity test, specifically in patients with idiopathic, heritable, and drug and toxin-induced pulmonary arterial hypertension. An acute response is defined as a mean pulmonary artery pressure reduction of more than 10 millimeters of mercury to a mean pulmonary artery pressure of less than 40 in the setting of an unchanged or increased cardiac output. If a patient meets those criteria at the time of the acute test, they can be treated with calcium channel blockers, but need to be followed for their clinical response. A patient who's a long-term responder is one who improves to functional class 2 or 3 with near normalization of the hemodynamics. So those patients are few and far between, but very important to identify as their long-term prognosis is excellent. Let's talk a little bit about the general measures for patients with pulmonary hypertension. There is not that much that's new here. Probably the most important new thing is that the anticoagulation data has become a little bit more murky, and outside of the patients with chronic thromboembolic pulmonary hypertension, anticoagulation is not routinely recommended in patients with pulmonary arterial hypertension. There's also a little bit more data on supervised exercise training, and we're being a little bit more proactive about trying to recommend that and trying to get patients in exercise programs. But the other things are still important: avoiding pregnancy, making sure they get the appropriate immunizations, often psychological counseling. There's a high incidence of depression in these patients. Some patients may need supplemental oxygen, and it's important to remember that we're not just talking about with rest and exercise, we're also talking about with altitude and sleep. It's important to make recommendations regarding surgeries in terms of anesthesia. The basics, including diuretics and managing anemia, are important. And the use of other cardiac medications such as ACE inhibitors and beta blockers is really only indicated for patients who have other comorbidities for which those medications are indicated. And atrial fibrillation is not well tolerated, and so treatment of that is important as well. Now let's look at the second section. The majority of the patients are not vasoreactive, and so what do we do? How do we make that initial treatment decision? Well, patients who are non-responders and who are at low or intermediate risk should be treated with initial oral combination therapy, and the data is best for an ERA and PDE5. But there are some subsets in which the efficacy to safety ratio of initial combination therapy is not well established, and we may consider initial monotherapy for some of those patients, particularly the low-risk patients. So who might those patients be? Who is appropriate for initial monotherapy? Well, for sure, the patients with idiopathic, heritable, and drug and toxin-induced pulmonary arterial hypertension who are responders to an acute vasoreactivity test and who, with calcium channel blockers, have a sustained response with a long-term improvement in their hemodynamics and exercise capacity. Those patients can be safely treated on their highest tolerated dose of calcium channel blockers. Again, few and far between. There are many patients that experts have in their practices who have been on monotherapy for a long time, 5 years, 10 years, and are doing well with a low risk profile. So we don't often add therapy to a patient who is doing so well. So those patients might be appropriate for initial monotherapy. There's another group of patients that we list here for a potential role of initial monotherapy, mostly because these types of patients haven't been included in the clinical trials of upfront oral combination therapy. And they include patients that are over 75 with multiple risk factors for heart failure with preserved ejection fraction, such as high blood pressure, diabetes, coronary disease, atrial fibrillation, and obesity. And then there are those patients that we suspect or have a high probability of having pulmonary veno-occlusive disease or pulmonary capillary hemangiomatosis. Again, those patients can go into pulmonary edema if we treat them too aggressively. And so if we treat them with pulmonary arterial hypertension specific therapy, we should do it a little bit more slowly and start them with monotherapy. Also listed in patients who might be appropriate for initial monotherapy are patients with PAH associated with HIV or portal hypertension or uncorrected congenital heart disease, as they were not included in any of the randomized controlled trials of combination therapy as an initial approach. There are some patients with PAH with very, very mild disease. Perhaps we've identified them via a screening program. So maybe they don't have symptoms, they have a very low PVR and mean pulmonary artery pressure and a normal right ventricle on echo. Those patients might be appropriate for monotherapy. And then there are some patients who are not appropriate because combination therapy is either unavailable or it's contraindicated, that it's not appropriate or safe to use one of the therapies, perhaps because of underlying liver disease. So the treatment algorithm was updated at the World Symposium. The background therapies that I'd like to highlight are the stronger data for exercise and for the weaker data for anticoagulation. We're not routinely using anticoagulation outside of CTEPH patients. And then we're getting more aggressive with therapy. Many patients will go on to combination therapy, but we've just highlighted the patients who might be appropriate for initial monotherapy. I hope you have enjoyed this update. Thank you for joining me.